Welcome to the deep dive. Today we're tackling Conn's syndrome.
That's right, also known as primary hyperaldosteronism.
Basically, it's where the adrenal glands get, well, a bit overzealous and pump out too much aldosterone hormone.
Exactly. And our mission today, using your MSRA revision notes, is really to pull out the high-yield stuff you need for revision.
Cover all the key points, yeah.
Oh, it gets thick.
Okay, so at its core, Conn's means too much aldosterone. And that causes a few key things, right?
Yep, the body hangs onto salt and water, which pushes up blood pressure. That's your hypertension.
Right.
Then you often get low potassium hypokalaemia and something called metabolic alkalosis, a shift in the body's acid-base balance.
Okay, let's unpack this a bit more.
So definition-wise, Conn syndrome is primary hyperaldosteronism. The key thing to grasp is how that extra aldosterone messes with the kidneys.
Specifically the distal nephron.
Precisely. Aldosterone basically tells the distal nephron to grab back more sodium and water.
Okay.
But at the same time, it tells it to dump more potassium.
So sodium retention leads to the high blood pressure.
Yeah, increased fluid volume, hypertension.
Yeah.
And the potassium dumping leads to the hypokalaemia. These shifts also contribute to that metabolic alkalosis.
Got it. So let's dig into the why, the etiology. The notes split it into primary and secondary hyperaldosteronism. What's the main difference there?
Okay, so primary means the problem is the adrenal glands themselves. They're just churning out aldosterone on their own.
Independent operators.
Pretty much. Whereas in secondary, the adrenals are fine, but they're being pushed to make more aldosterone because there's too much renin floating around.
Ah, okay. Renin's the signal.
Renin's the signal, and it's coming from somewhere else, telling the normal adrenals to overwork.
Okay. So focusing on primary first. The big one, over 80% of cases, is an adrenal adenoma.
Yep, a single benign tumor on one adrenal gland. That's Conn syndrome in the strictest sense.
Right. What else falls under primary?
Well, then you've got bilateral adrenal hyperplasia, BAH. That's where both glands are enlarged and overactive, about 15% or so. Then there are the familial types inherited forms. Type 1 is GRA, glucocorticoid remediable aldosteronism. Tends to show up early, can cause pretty tough to treat hypertension. Type 2 is more of a genetic tendency towards getting adenomas or BAH.
And the last one?
Adrenal carcinoma. That's rare, thankfully. It's a cancerous tumor, sometimes only found after surgery for what they thought was a benign adenoma.
Right. Now the secondary causes, that's where renin is high.
Exactly. High renin stimulating normal adrenals. Think about situations where the body thinks volume or pressure is low.
Like with diuretics?
Perfect example.
Yeah.
Diuretics can trick the body. Also heart failure, liver failure, nephrotic syndrome, and the classic one is renal artery stenosis, narrowed kidney arteries. The kidney senses less blood flow, panics, and shouts, more renin.
Okay. Makes sense. Even malignant hypertension can do it.
Yes, that severe, rapid rise in blood pressure can also trigger that secondary aldosterone release.
So it's either the adrenals themselves or something else kicking them into gear. Who usually gets Conn's? Any typical risk factors?
Well, the typical age for diagnosis is somewhere between 30 and 50.
Okay.
Family history is a big one, especially for those familial types we mentioned, like GRA.
Right.
And maybe having existing high blood pressure or cardiovascular disease could slightly increase the chance that primary hyperaldosteronism is the underlying cause. It's something to bear in mind.
Okay. So if we zoom back in on the pathophysiology, the chain reaction, walk us through that again, simply.
Sure. Step 1, dodgy adrenal glands secrete way too much aldosterone.
Right.
Step 2, that extra aldosterone hits the kidney's distal tubules.
The salt and water regulators?
Exactly. It cranks up sodium and water reabsorption back into the blood and pushes potassium out to the urine.
Leading to?
Fluid retention, which means hypertension, and potassium loss, which means hypokalaemia potentially. Hypertension and low potassium often linked.
Okay. But Conn's isn't the only thing causing high blood pressure and weird electrolytes, is it? What about the differential diagnosis?
No, definitely not. You've got to rule other things out. A good way to think about it is using renin levels.
Okay.
If you have high aldosterone but low renin, that screams primary adrenal problem.
So the adenoma, BAH, GRA, carcinoma we talked about.
Yep. And also things like congenital adrenal hyperplasia. The adrenals are the source. Renin is suppressed because the body knows there's too much aldosterone.
Makes sense. And what if renin is high?
High renin with high aldosterone points towards secondary causes. Something outside the adrenals is driving renin up.
Like renal artery stenosis?
Classic example. Also, coarctation of the aorta, fibromuscular dysplasia, those rare renin-secreting tumors,
Okay.
congestive heart failure, nephrotic syndrome, certain kidney things like Gilman's or Barter's syndrome, and of course, diuretic use. Always check the meds.
So renin is a really helpful fork in the road diagnostically. Any other specific conditions to exclude?
Yeah, you'd also think about Cushing's syndrome, different mechanism that cause hypertension.
Mm-hmm.
Pheochromocytoma, the adrenaline surges, got to rule that out. And, the most common reason for high blood pressure is just essential hypertension. So that's always on the list.
Good overview. Now, epidemiology. How common actually is Conn syndrome?
It's tricky to know the exact number, but estimates are somewhere in the 1 to 10% range for people with hypertension.
Okay, not insignificant.
No, and it seems to be a bit more common in women, usually diagnosed, as we said, between 30 and 50.
And what about primary hyperaldosteronism overall, including BAH and the others?
That's thought to affect maybe 5 to 10% of all patients with hypertension. But here's where it gets really interesting.
Go on.
It's considered the most common curable cause of secondary hypertension.
Curable. That's huge.
It really is. Unlike essential hypertension, where you're usually managing it long-term, here you potentially have a fix. That's why spotting it is so important.
Absolutely. So what are the clinical features, the signs and symptoms that should make you think, maybe this is Conn's? What are the red flags?
Well, the biggest one is hypertension, especially if it's hard to control with the usual meds. Resistant hypertension.
Okay.
Now, the classic teaching is low potassium, hypokalaemia. And patients might have muscle weakness, cramps, maybe tingling. And this is really crucial for revision. Hypokalaemia isn't always there. Maybe only 10 to 40% of patients actually have low potassium.
So you can't rely on that alone?
Absolutely not. Normal potassium doesn't rule out Conn's. Big take-home point.
Okay. What else might you see?
Metabolic alkalosis on blood tests, high bicarbonate, maybe increased thirst and urination, polyuria, nocturia, because the kidneys aren't concentrating urine properly.
Right.
And then there are less specific things, fatigue, trouble concentrating, even mood issues like irritability, anxiety, depression. Rarely you might get more severe things like muscle spasms, tetany, or even cardiac arrhythmias from the electrolyte disturbance.
So resistant hypertension is the main trigger for suspicion.
It's a major one.
Yeah.
Resistant hypertension, maybe with low or even borderline low potassium or any of those other features, should prompt screening.
And the go-to screening test is?
The aldosterone to renin ratio, the ARR. Generally, an ARR over 30 NEDL per NG-mLH with an aldosterone level over 15 NGDL is considered a positive screen.
Okay, ARR is the starting point. If that's high, what are the next investigations?
Right, if the ARR flags it, you'll want blood tests to confirm the high aldosterone and check that renin is indeed suppressed. Then you move to imaging.
Adrenal CT scan.
Usually, yeah, to look for an adenoma or signs of hyperplasia. But the CT isn't perfect at telling you which gland is the problem or if it's both.
Which is where?
Adrenal vein sampling, or AVS, comes in. That's really the gold standard for figuring out if the aldosterone excess is unilateral, just one side, or bilateral, both sides.
How does AVS work?
It's quite specialized. They basically thread catheters into the veins, draining each adrenal gland, and take blood samples directly to measure aldosterone output from each side.
Very precise.
It is. And it's crucial because it guides treatment surgery for unilateral, usually meds for bilateral.
Makes sense. Any other tests?
Well, an ECG is sensible to check for heart rhythm issues from electrolyte problems. Genetic testing if you suspect a familial type. And cross-sectional imaging generally helps rule out that rare adrenal cancer.
What if the ARR is sort of borderline or things aren't clear-cut?
Good question. That's when you might use confirmatory tests. Things like the fludrocortisone suppression test, saline infusion test, oral sodium loading, captopril challenge.
Okay.
These are all basically aldosterone suppression tests. They challenge the body to see if aldosterone production suppresses normally. If it doesn't, it confirms the diagnosis.
So quite a few steps involved.
It can be, but AVS is key for localization if you're considering surgery. Differentiating that single adenoma or carcinoma from bilateral hyperplasia is vital.
Is there an easy way to remember the main investigation steps?
You can think of the A-team for investigation.
The A-team, okay.
Aldosterone levels, the ARR, adrenal imaging like CT, and AVS, adrenal vein sampling. Those are your core four.
Aldosterone, ARR, adrenals, AVS.
Got it. That's helpful. So once you have the diagnosis, how do you manage Conn's? What's the approach?
The main goals are pretty straightforward. Get the blood pressure under control and fix the electrolytes, especially potassium.
Right. Medications first.
Often, yes. The key drugs are mineralocorticoid receptor antagonists, or MRAs. things like spironolactone or epinephrine. They block aldosterone's effects.
And surgery, adrenalectomy.
Yep, surgical removal of the gland adrenalectomy is a great option if AVS confirms the problem is coming from just one side, like a unilateral adenoma.
So the AVS result really dictates the path.
Largely, yes. If AVS shows unilateral disease and the patient is suitable, surgery is often preferred. If it's bilateral or if surgery isn't an option or desired, then it's typically lifelong MRAs.
Need to be careful with the MRAs, though.
Definitely. You don't want to overtreat and cause dehydration or kidney issues. That pre-renal failure picture, careful monitoring is needed.
What about those familial types like GRA? Ah, yes, for GRA, the first line is often low-dose glucocorticoids, dexamethasone or prednisolone. They can work really well and quickly for the hypertension. MRAs might be added later if needed.
And before surgery, anything specific?
Oh yeah, preoperative optimization is key. You want to get the blood pressure well controlled and the potassium levels corrected before the operation.
Improves outcomes.
Absolutely. Better recovery, fewer complications. And if the unilateral adrenalectomy works, it can actually cure the hypertension in about 55% of people.
Cure. That's amazing.
It is. And even if it doesn't fully cure the hypertension, it almost always corrects the hypokalaemia and generally improves quality of life significantly.
And for bilateral disease, it's lifelong MRAs.
Typically, yes. Spironolactone or Epler run for life, though surgery might occasionally be considered even in bilateral cases if one side seems overwhelmingly dominant.
Okay. And just quickly for secondary hyperaldosteronism.
There, you treat the underlying cause. Stop the diuretic, manage the heart failure, fix the renal artery stenosis if possible, address the root problem driving the renin up.
Right. Let's try that example question again. A 45-year-old woman, resistant hypertension, low potassium, screen for.
Primary hyperaldosteronism, Conn's syndrome. Definitely.
Perfect. So, thinking long-term, what's the prognosis like for someone with Conn's?
Generally, it's very good if it's diagnosed and treated properly. Controlling the blood pressure and potassium really lowers the risk of long-term problems.
And for primary hyperaldosteronism overall?
Also pretty positive with treatment, but many patients, even after successful surgery for an adenoma, might still need some antihypertensive medication long-term.
Oh, really? Even after surgery?
Yeah, especially if they were diagnosed later in life and had high blood pressure for a long time before the Conn's was picked up. Some underlying essential hypertension might remain.
I see. Are there other long-term things to consider?
Well, we know excess aldosterone isn't great for the heart. It can cause damage like myocardial fibrosis.
Right.
The good news is that MRAs like spironolactone seem to help counteract that. There's the RAM study in heart failure showing spironolactone reduced mortality. And the thinking is it probably offers similar heart protection in primary hyperaldosteronism beyond just lowering blood pressure.
So treatment isn't just about BP and potassium, it's potentially cardioprotective too.
Exactly. So overall, the outlook's good with treatment, but lifelong BP monitoring is often needed, and MRAs play a key role. It really makes you think, doesn't it, about digging deeper in some hypertension cases.
It really does. Finally, what if it's missed or not treated well? What are the complications?
Untreated Conn's significantly ramps up cardiovascular risk. Stroke is a big one. Kidney damage, too. Arrhythmias from the electrolyte issues, and just the general effects of chronic hypokalaemia.
And for primary hyperaldosteronism generally?
Same sort of things. Risk from uncontrolled hypertension, the electrolyte chaos, cardiovascular events, kidney problems, arrhythmias. And, you also have to consider potential long-term side effects of the MRA treatment itself, though usually manageable.
So bottom line, early diagnosis and proper management are crucial.
Absolutely vital to avoid those serious downstream effects.
Okay, let's try and summarize the key takeaways for revision. Conn syndrome, primary hyperaldosteronism, usually an adrenal adenoma, too much aldosterone.
Leading to hypertension, often resistant, and potentially low potassium. But remember, potassium can be normal.
Right. Investigation involved the A-team, aldosterone, ARR, adrenal imaging, and often AVS for localization.
Treatment depends on unilateral versus bilateral. Surgery, adrenalectomy, for unilateral if suitable, MRAs, spironolactone, Renin, for bilateral or if surgery isn't done.
And it's a potentially curable cause of secondary hypertension, so really important to keep it on your radar.
Definitely. High index of suspicion in the right clinical setting is key.
Well, that was a really thorough and I think super helpful deep dive into Conn syndrome. Great for revision.
Hope so.
And for more brilliant resources to nail your MSRA revision, don't forget to check out PathSimsSRA.com.
And also freemsra.com for loads of free questions and guides.
Excellent. Until our next deep dive, keep learning.